Good morning. So now I'm going to talk about the psychiatric disorders in ASD and the management strategies. So what are the aims of the presentation? As the topic says that we are going to discuss about what are the common conditions. I think some of the things are already covered by other speakers. Then what do we do for those patients? Why is it important? Why do we have to worry about any comorbid conditions? We know that autism is a major public health concern due to early onset, lifelong persistency, then it causes high level of functional impairment, not only to the child, to the whole family. So when problems or the behavioral difficulties are identified, which is related with the comorbid condition, so we can offer the specific treatment for comorbid condition. Like for example, if you are going to any surgery, they always check for blood sugar level, high blood pressure, and the cardiac rhythm, because to get the better outcome of the surgery. Similar to this, we need to identify and treat the comorbid condition associated with ASD to get the better prognosis. Okay, the prevalence, you have noticed, I think there are a huge variety of difference in the prevalence rate of even autism, even with other comorbid conditions, because each paper says the different prevalence. So generally, 70 to 92% of the autistic kids have at least one comorbid condition. Then 41% of them are having 2 or more comorbid conditions. So what are the common psychiatric conditions? I think we have already covered it. So this slide covers the common comorbid conditions like ADHD, anxiety disorder, or the depression or sensory disturbances. Then other behavioral difficulties include sexualized behavior, self-injurious behavior, and the sleeping difficulties. Trichotillomania, which is a habitual disorder, like the children tends to pull out their hair. It can cause the severe damage to their skull. Then enuresis and encopresis, it is an incontinence. Now we are going to discuss about mainly briefly about each comorbid condition. The first one is intellectual disability, which is a lower IQ level. If the IQ level is between the 70 and 50, which is classified as mild, 50 to 35 is moderate, less than 35 is severe. So the studies have shown that 40% of the autistic kids are having intellectual disability, 30% of them are having mild or moderate cognitive impairment, 30% of them are having normal IQ level. One study which was done in the population of intellectual disability kids, which showed 10% of the intellectual disability kids are having autism. It is a challenging task for the professionals itself to diagnose whether the social impairment is actually due to autism or actually due to intellectual disability when the kids are having both conditions. So it needs thorough assessment and the expert opinion based on the multidisciplinary team approach. Coming to the management, we all know that we cannot cure the intellectual disability, but our goal is to improve the standard of the life. As I mentioned earlier, not only the child's standard of life, to the whole family standard of life. Because if any child or if anybody gets unwell in our family, it affects everyone's physical and mental health. Then obviously we are going to aim to help the child to be independent. So the treatment is based on the severity and the needs of the family and the child. So the strategies are mainly the behavioral strategies like giving one-to-one sessions or the special school, especially in Western countries. Most of the places, they do have the special school. Even in the normal school, they do have separate inclusion unit, because even though ASD kids are having high IQ level, still they may struggle to adjust some of the situation in the school. I hope in future, in India also, we will have more specialized school, because it's all coming up slowly. Okay, the next one is ADHD. Again, the prevalence varied from each papers, like generally 29 to 78% of the autistic kids are having ADHD. One paper looked into the prevalence between the male and female. Then as usual, the males are having more prone to have ADHD. We are going to have separate session in the afternoon, so just briefly regarding the management. Generally mild, moderate, and the ages, if the child's age is less than 6 years, we wouldn't suggest the medication option for ADHD, mainly the behavioral strategies. But if it is a severe condition, or if the child is more than 6 years, it is very disruptive, means we do offer stimulant or non-stimulant medication. Then again, the specific learning difficulties like difficulty in reading or writing or spelling. The first thing is, after assessing the child, we need to make the parents to understand the child is having the specific learning difficulties. Because we do see in our clinic, the parents will come and say that his memory power is brilliant, doctor, but he's not able to write it. He is very lazy, doctor. But some of the kids are like that, but we have to identify whether actually is the child is lazy or does the child have any other specific learning difficulties. So obviously, if the child is having specific learning difficulties, the child needs special education. The dyspraxia, which is a motor coordination difficulties. In general population, dyspraxia is associated with higher autistic traits and the lower empathy. The basis behind is, like, to have the better communication skill, we need a better motor coordination skill. Like, for example, if we have to make the good eye contact, if we have to show the good body language during the communication, we need the better motor coordination skills. Then autism with school issues, even though autistic child has higher IQ level, they still struggle to adjust in the school environment due to they may have difficulty in making friends. Then they have difficulty in adjusting to the different classes because they have to go out for the PE lessons or the computer classes or music classes. Or they have the different teachers for each subject. So they need extra care. This is how the special inclusion unit for the autistic kids would help them to have a better education. Then obviously, if the ASD kids are having some learning, intellectual disability, means they need special education. The challenging behavior, I think it was mentioned in the previous topics as well. So the challenging behaviors can be anything, like the simple screaming, throwing things, temper tantrum, or sexualized behavior or self-injuries. So basically, we need to identify the cause, then we need to treat the cause. So what are the causes of the challenging behavior? So simply, it could be due to lack of communication skill. For example, 3-year-old girl with the diagnosis of autism, definitely the child would have had the speech delay. So if the child wants something, she's going to pull mom's hand. Mom might be busy with something in kitchen or looking at the WhatsApp. Then mom can explain it, oh, I will come in a minute. But the child cannot understand the concept because that is the part of the autism. Then the child will show all the temper tantrum and the screaming. Then this is how the child is learning that behavior and getting attention seeking. Then other thing is the environmental changes, like going to the new places or missing some family members could lead to the challenging behavior. Then the puberty changes, I think it was covered in the previous topic. Then poor sleep hygiene, we are going to discuss about later. Then the self-injurious behavior. When compared to other developmental conditions, autism has the higher prevalence of self-injurious behavior. Simply, it can be head banging or hand biting, scratching, or rubbing their face or hands with other surfaces, like for simple example, the walls. The treatment is functional analysis. What is functional analysis? It is nothing but taking the detailed history of the circumstances, and we need to identify the pattern of the behavior. Then we need to find out whether this behavior is related with the frustration or whether this behavior is related with the self-stimulation. So when we identify the cause, it's easy to treat it. Then some of the studies have proved some physiological reason behind the repeatedly doing the self-injurious behavior. For example, when the child is rubbing their hands or scratching their hands, the particular substance called beta endorphin is released from their body. It gives the smoothing effects to the child. So the child relieves the pain. The child gets relieved the pain. So the child will tend to do it again and again. Then very rarely we need to rule out the seizures activity, because some of the self-injurious behavior, for example, like this, some of the child can do like hit their hand with the one hand. It appeared as focal seizures. Even though it is rare, we need to rule out this. Then I think in our clinical practice, we had that experience of some of the parents will come and say that, doctor, if I give that particular diet, that self-injurious behavior is more. Actually, there is no evidence that any particular diet is causing increase the risk of self-injurious behavior. But however, when the parents identify something, there is no harm in advising the parents to avoid it, as long as if the child is taking enough nutrients. The sleep difficulties, nearly 2/3 of the kids with autism are having the sleep difficulties in the form of insomnia, nightmares, night terrors, or the sleepwalking. Before moving to the medication option, we have to try the good sleep hygiene. Not only the child, the family should follow the good sleep hygiene, because nowadays, because of the social media, even we are not adult, we are not following the good sleep hygiene. So before moving to any medication, especially with the child, because already Dr. Kannan mentioned that, please make sure we try all the sleep hygiene or the behavioral strategies before starting the medication. Then coming to the sexual behavior, it is not very common, but at the same time, it is not very rare. Generally, the child may do masturbation or exposing genitalia in the public places. I had a 6-year-old child who was brought to my clinic with the history of doing masturbation almost every day. It was not here, it was in UK. Then initially we suspected sexual abuse. But later we found that he has observed other brothers and their friends. They're all teenagers. So they were all practicing masturbation in a private room. So the child observed it, then the child learnt it. So we have to teach the child which is good behavior, which is bad behavior, because the child is only 6-year-old. The other thing is, I had another case of 14-year-old boy with severe intellectual disability with autism. The child attends a special school. The main complaint is the child is doing masturbation in the school. So every time when the child does the masturbation, the child was sent to home. Then when we took the functional analysis, we found that if the child gets bored in the school, he will start doing the masturbation, so that he knows that he can be sent home. So the treatment is, we have to advise the teachers, where the parents, don't send him back to home, send him to the private room, then he'll be fine. Then it's worked, then he stopped doing that behavior. And also we need to teach the parents that doing masturbation is not a crime or something, because the child is 14. Even though if the child is having the intellectual disability, he has the rights to enjoy the nature. So we have to teach the parents, allow him to do masturbation in a private room in the particular time. It works really well. Then enuresis and encopresis. Again, it is not very common. In those things, first we need to rule out the medical causes, because autism is associated with lots of genetic and other developmental conditions. Then mainly the psychological reasons are, it could be due to fear or it could be due to attention seeking. I had a case of like 11-year-old boy with a normal IQ, but with the severe autism. He was attending the special inclusion unit. With the 3 years history of his smearing feces everywhere in his room for the last 3 weeks. Then just imagine his mom's situation, because mom has to clean his room every day. Then when we identify the pattern of the history, then we noted that one of his younger sibling was physically unwell. So the parents was looking after that younger sibling. They didn't have a time to look after these elder kids. So to get the attention, he started smearing feces everywhere in his room. So we need to identify the cause, then we need to treat it. 4 minutes, okay. Then coming to anxiety, social anxiety disorder is very common in autism. Nearly 29% of the autistic kids are having social anxiety disorder. because autistic kids are more prone to have social anxiety because they have difficulty in making friends, they have difficulty in going to the newer places. So the treatment is obviously the psychotherapy like cognitive behavioral therapy and medication. Then the sensory difficulties, nearly 76% of the ASD kids are having sensory difficulties. The treatment is mainly it's associated with to avoid the particular texture or the taste, smell, sound, or some limited diet. The treatment is, if it is possible, we can avoid that particular stimuli, or we have to do the desensitization by graded exposure. The depression, 30% of the autistic teenage kids are having this depression. Mainly, it's very common in the higher functioning autistic kids. The treatment is, most of the psychiatric conditions, it's a combination of the medication and the psychotherapy. Obsessive compulsive disorder is also common in autistic kids because of the condition of the repetitive behaviors and the thoughts. Tourette syndrome, which is a combination of the motor and the vocal tics. 11% of the autistic kids are having the Tourette syndrome. The treatment is the psychobehavioral therapy. But if any child is having the Tourette syndrome or the mild tics, but if it is not affecting their functioning level, we don't have to treat it. But most of the time, what would happen, the child will get bullied at school. So in that case, we have to intervene. The next one is the psychosis with autism. I think regarding the Leo Kanner, already it was mentioned in other two topics, so I'm going to skip it. So some of the symptoms are overlapping between the psychosis and autism. For example, features of ASD are misdiagnosed as psychotic symptoms, where the difficulties in reading was interpreted as paranoid ideas, difficulties in expressive communication as interpreted as thought disorder, and feeling meltdowns as interpreted as catatonia. Catatonia is a type of schizophrenia, just simply they go mute. So the treatment is antipsychotics. Then what is the relationship between the affective disorder, which means it's a combination of the depression, bipolar disorder, and the anxiety disorder with autism? The studies have proven that a higher rate of bipolar disorder, anxiety disorder in the families of ASD, and vice versa in the increased risk of ASD in families with history of schizophrenia and bipolar disorder. The basis behind this is these conditions shares the common risk pathways like mainly stress vulnerability model. And also they found some of the common genes like FOXP2 in ASD as well as in the affective disorder. So the other disorders, obviously this oppositional defiant disorder or the conduct disorder, which is an extreme form of behavioral difficulties like throwing things, breaking things, stealing. Most of them, especially in the conduct disorders people, they can be arrested by police as well. The treatment is the behavioral strategies. So the conclusion is comorbid conditions could appear at any time. Autism is not a simple condition, it is a very complex condition. So it needs a multidisciplinary team approach for the diagnosis and the treatment. That's what Nesto is offering to you. Thank you so much.